So I have a case to present tonight that is a a patellofemoral case, and obviously rehab is altered when you're dealing more with the patellofemoral joint rather than the traditional weight-bearing tibiofemoral joint. So in this case, this is a 35-year-old woman, healthy body weight, active in running and cycling, has a long history of some patellofemoral pain. Previously had a lateral release done to treat some patellar tilt, kind of presented to me after that. She presents, aside from symptoms of the anterior knee pain, mainly with complaints of recurrent effusion after running or cycling, which I do often find to be one of the reasons people seek this procedure when they just can't be active without developing a post-activity effusion, which is really quite bothersome to people and just their day-to-day activities after working out. So as I mentioned, previous scope with lateral release, has done some more PT, has had a steroid injection, and she presents essentially looking to be able to resume regular exercise without developing a huge knee effusion. So on exam, she does have valgus alignment, presents with a moderate effusion, fairly well-preserved range of motion, flexion limited by the size of her effusion on any given day, no instability. Again, we mentioned previous surgery with chondroplasty, but no microfracture, also lateral release. X-rays, which I'll show you in a moment, show slight narrowing at the lateral aspect of the patellofemoral joint, but otherwise normal joint spaces, no significant degenerative joint disease diffusely. And then I'll show you some cuts of her MRI where we can see that defect affecting the lateral facet as well as the apex. And a somewhat elevated TTTG, nothing crazy, but a little bit high on the sort of normal side, and no major comorbidities. So her merchant view there demonstrates really no remaining significant tilt, probably due to her previous lateral release, a little bit of narrowing the joint space there. And then you can see on that axial image from the MRI, there's basically near full thickness loss or full thickness loss at the lateral facet, sort of creeping over to the apex. And then just on measurement of her TTTG for preoperative planning purposes for an unloading osteotomy, I measured there a bit over 17 millimeters. So at her initial arthroscopy, ligamentous meniscal structures all intact. She did have this large defect of the patella affecting the lateral facet and apex region. Opposing surface intact, so no major trochlear abnormalities, no bone loss. So our surgical plan at that time was essentially to take a biopsy with plan for return to OR at some point for the unloading tibial tubercle osteotomy with anterior medialization, and then MACI to be applied to the patella. And based on the size of her defect, it was determined that one implant would be used. So at the time of surgery, this more oval cutter was utilized to prepare the defect. Her tibial tubercle was osteotomized, and after completion of the MACI procedure, was then repaired back with these two bicortical 3.5 millimeter screws with some anteromedialization. The post-operative course, in this case, is somewhat driven by the osteotomy, but also our early restrictions. We have a gradual progression of the range of motion. For instance, just in the first, week or so, we're just doing very limited 0 to 20 degrees of motion, and then gradually working up. We could go a little farther at 6 weeks or a little bit, at the 5 to 6 weeks marks, but I usually limit this to 90 degrees for the first 6 weeks due to the osteotomy. Weight bearing early on is protected and then gradually progressed up to weight bearing to tolerance in extension by 6 weeks. And then when we start our weight bearing flexion at 6 weeks, this is again gradually progressed due to the osteotomy. So in general, no running or jumping until 6 months post-op. I would say that this person was able to get back to regular working out on the stationary bike without recurrent effusions, which was her main goal. She has resumed some running to a lesser extent, and she does this in combination with just sort of cross-training efforts. So this has been a successful procedure for her. For your patients, they do have this added resource available through Vericel. We have patient ambassadors. This case study is this patient. This is Rachel. She's an excellent, educator to our patients. Really smart PhD who has gone through this process and likes to share her experience. So people like her are a wonderful tool to patients to kind of educate them about what their process might be like. And these ambassadors have participated in events like this, sort of just, again, sharing their experience to make this information more patient-facing and patient-friendly, for your patients. So, and there she is participating in one of these events. So I don't know if we want to do questions right now or next case study. Cassandra, I'll leave that up to you.
I think we have a couple minutes. So if anyone has any questions, or if not, then I might jump in. All right, so I'm going to ask a little bit with an isolated patella chondral lesion. Do you have any issues with any hypertrophy or overgrowth? And how do you approach that?
I haven't had any issues with hypertrophy since, in the earliest versions with use of the periosteum as the surface layer, there was a high rate of hypertrophy. But with subsequent versions, especially with the MACI version, I have not had any hypertrophy or overgrowth in the patella. But in the past, when I experienced this with use of periosteal flap, that was generally treated with kind of shaving it down. Debridement would almost overgrow too much cartilage in the area. So I have not experienced that with MACI at all.
So what if you have what we call is a uncontained lesion? So say that it doesn't have a border on, say, the lateral aspect of the patella. Do you do anything different? Do you do add fixation? Do you add sutures, more glue? What do you do?
Yeah, I mean, if there's like a little layer of tissue, I can pass suture through. I've done that. I've also used like, some small anchor, like a very small all suture type anchor at the edge, that kind of thing, combined with glue. That can happen at the edge of the patella. Usually there's a small little rim of something to insert it into.
Yeah. I would say personally, I don't really worry about the uncontained lesions as much as being an older kind of MACI surgeon or ACI surgeon. I don't hesitate. Like if it's a very large lesion or even uncontained or somewhere where maybe aggressively in terms of range of motion, it might kind of peel off, I actually don't hesitate to throw a suture, like a 6-0 vicryl suture, like the old fashioned way, just to pull it to the side. I don't really worry about putting suture anchors in because we're not filling cells into fluid there anymore. Since the cells are implanted, they'll migrate very consistently into the bone. So I just go ahead and just tack the membrane to an adjacent piece of the cartilage somewhere to give me that little extra so I can sleep at night.
Yeah, and sometimes, again, there's not like sometimes it's not necessarily contained by a chondral rim, but there's like a tissue rim, something where the membrane is not going to get like basically scraped off at that edge. So yeah, I think you do have a lot more flexibility when you can kind of just inset it, glue it, and it doesn't have to be watertight like it used to be. Yeah.
You can also limit their range of motion a little bit more in the beginning if you're concerned about it, so they're not being overly aggressive and worrying about that lesion and the graft coming off. I've done the same thing of trying to, use some 6-0 Proline to kind of tack it into something and really range them in the OR to make sure it's not moving. And there's been a couple times I'm like, it bubbled a little bit here. I'm just going to throw something to make sure it doesn't move.
I had one yesterday where the grafts were starting to migrate my medial and lateral. It was a 3 defect medial, lateral, and trochlea. And I did do some suture tacking on my medial and lateral because it was, when I ranged it, it migrated a little, but I typically don't either. I usually don't need to. The glue typically works well.
Indication for use. MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product that is indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the adult knee with or without bone involvement. MACI is intended for autologous use and must only be administered to the patient for whom it was manufactured. The implantation of MACI is to be performed via an arthrotomy to the knee joint under sterile conditions. The amount of MACI administered is dependent upon the size, surface in centimeters squared, of the cartilage defect. The implantation membrane is trimmed by the treating surgeon to the size and shape of the defect to ensure the damaged area is completely covered and implanted cell side down. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, or products of porcine or bovine origin. MACI is also contraindicated for patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. MACI is also not indicated for use in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant. MACI is contraindicated in patients who are unable to follow a physician-prescribed post-surgical rehabilitation program. The safety of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of present malignant or dysplastic cells during the culturing process or implantation is possible. Patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases. A cartilage biopsy and MACI implant may carry the risk of transmitting infectious diseases to healthcare providers handling the tissue. Universal precautions should be employed when handling the biopsy samples and the MACI product. Final sterility test results are not available at the time of shipping. In the case of positive sterility results, healthcare provider or providers will be contacted. To create a favourable environment for healing, concomitant pathologies that include meniscal pathology, cruciate ligament instability, and joint misalignment must be addressed prior to or concurrent with the implantation of MACI. Local treatment guidelines regarding the use of thromboprophylaxis and antibiotic prophylaxis around orthopedic surgery should be followed. Use in patients with local inflammations or active infections in the bone, joint, and surrounding soft tissue should be temporarily deferred until documented recovery. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to infant has not been determined. Use of MACI in pediatric patients younger than 18 years of age or patients over 65 years of age has not been established. The most frequently occurring adverse reactions reported for MACI greater than 5% were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. For more information or to view full prescribing information, please go to maci.com.